Welcome to Section 2 in Pulmonology. In this section, we will discuss spirometry, lung volumes, and lung capacities. So let's get started. To understand lung volumes, you need to understand spirometry. Spirometry uses a clinical tool called a spirometer to determine lung volumes and lung capacities. Capacities are simply two or more lung volumes. In addition to obtaining information on lung volumes and capacities, a spirometer can determine how fast a patient is breathing. For example, the clinician can tell the patient to exhale as fast as the patient is able to in a single second to find the forced expiratory volume, or FEV1, the 1 referring to 1 second. So this measures how much volume the patient can exhale in 1 second. The data from spirometry can be used to generate various graphs, such as a spirogram, a flow volume loop, or a flow versus volume graph. Overall, the whole point is to assess lung function, or PFTs, which stands for pulmonary function test. So a patient can undergo PFTs, which will give you the data from spirometry. One thing to remember is that simple spirometry cannot measure residual volume, or RV, at least not without an additional technique such as helium dilution or nitrogen washout. So now let's look at a spirogram. So this is figure 3.3 from your text, and we're actually just going to draw this out quickly, step by step on the next slide. Okay, so let's first set up our graph for the spirogram. So this is the y-axis, and then here's the x-axis. The y-axis is volume. And in a traditional spirogram, conceptually, we'll not actually have any units on the bottom, but in concept, it's supposed to be time. But we'll just keep it simple right now. So the first thing we're going to talk about is tidal volume. So that's the patient inhaling and exhaling as normal at rest. And so traditionally, to understand this, we will draw lines. So tidal volume, TV, is simply the volume of air the patient is breathing in and out at rest. Normally this is around 500 milliliters. So now let's continue. From the point of normal inspiration, right here, you can then instruct the patient to inhale as much as they possibly can, like this. Once they have done that, you now have inspiratory reserve volume. Think reserve because that is how much extra volume the patient can inhale when they try as hard as they can. Then, once the patient is breathing normally again, the patient can then be instructed by the clinician to exhale as normal again. And then from that point, the patient can exhale as much as possible, bringing us to this point right here. And this is how you obtain expiratory reserve volume. Reserve because this is how much extra volume the patient can exhale when they try as hard as they can. The volume of air that is left in the lungs, anything below this line, is considered residual volume, or RV. So this is the amount that the patient cannot exhale, and we will come back to this in a minute. Now on to capacities. Capacities are simply two or more volumes added together. So inspiratory capacity is how much volume the patient can inhale total. So from here to here, that's inspiratory capacity. The next capacity is functional residual capacity. So when the patient exhales as normal along this line, the FRC, functional residual capacity, is simply how much volume remains in the lungs total. So it even includes residual volume. So FRC, functional residual capacity. So the next capacity is vital capacity. You will actually also see FVC, as in FEV1 over FVC ratio. And the FVC, the forced vital capacity, is the denominator in this ratio. So let's erase this and show what vital capacity is. So this vital capacity, or forced vital capacity, is the volume of air that the patient can move around. So everything except that little bit of residual volume down here. Finally, there is total lung capacity, or TLC. So this is the total volume of air, everything including what the patient can maximally inhale, IC, as well as the volume remaining after normal expiration, FRC. However, before we mentioned that spirometry cannot detect residual volume. If spirometry cannot measure residual volume, then it cannot measure any of the capacities that rely on residual volume. Which capacities rely on residual volume? Functional residual capacity and total lung capacity. As you can see, you clearly need residual volume to obtain FRC and TLC. So how does one obtain residual volume, functional residual capacity, and total lung capacity without spirometry? The reality is that you can use spirometry, but you need to add an additional technique such as helium dilution or nitrogen washout. So let's talk about that briefly. So helium dilution and nitrogen washout are used to determine first functional residual capacity. I know on the last slide that I said you cannot determine functional residual capacity unless you first determine residual volume. The reality is that in clinic you actually measure FRC and then mathematically derive RV, residual volume, and then of course TLC as well. Once you have functional residual capacity, you can then determine residual volume and total lung capacity, but you have to use a little bit of math. So as written here, you can find functional residual capacity through this additional technique, helium dilution and nitrogen washout, either or, and then you add it to inspiratory capacity to find total lung capacity. So just recall, if this is our normal spirogram, inspiratory capacity is from here to here, and then functional residual capacity is the rest, and then total lung capacity is both of these combined. So we already had IC, and then this added technique gives us FRC, so then we can easily determine TLC by adding IC and FRC. So now how do we determine residual volume, everything beneath this line? So now we have total lung capacity, and then we also have from normal spirometry vital capacity, which is this whole volume, VC, vital capacity. So if you take total lung capacity and subtract vital capacity, you'll get residual volume, everything down here. So don't get too wrapped up in helium dilution and nitrogen washout. The only point is to recognize that unless a question stem states helium dilution or nitrogen washout as being a part of the spirometry technique, then you need to assume you're not getting residual volume, total lung capacity, or functional residual capacity. Okay, and just to review, the lung volumes are tidal volume, TV, and you may also see V with the subscript T for tidal. And then we have inspiratory reserve volume, expiratory reserve volume, and residual volume. And then capacities are two or more lung volumes. So we have inspiratory capacity, vital capacity, and you may also see forced vital capacity. And then we have functional residual capacity, FRC, and then total lung capacity, which is all the air that is in the lungs total. Now we will talk about obstructive and restrictive lung diseases. First I will talk about obstructive and discuss the associated spirogram. Then I will discuss restrictive lung diseases and their associated spirogram findings. Then I will introduce flow volume loops and compare the obstructive spirogram to the obstructive flow volume loop. I will do the same comparison with restrictive lung diseases. Now let's dive into obstructive lung diseases. So in obstructive lung diseases, the air becomes trapped inside the lungs, so the patients can't get as much air out. In other words, they can't fully exhale. Another way of saying this is that the total lung capacity has increased. And this is because if you can't fully exhale, then the residual volume will increase. And if you have increased residual volume, then you're going to have increased functional residual capacity and total lung capacity. Now this could occur for many reasons, and it should make you think of diagnoses such as chronic bronchitis, emphysema, asthma, or bronchiectasis. Now the vital capacity, or forced vital capacity, stays relatively normal unless the patient also has a restrictive disease. Now tidal volume, or V subscript T, remains normal, but it takes longer for the patient to exhale. So FEV1 will decrease. In fact, in these patients, FEV1 has decreased significantly because that's the primary problem with obstructive lung diseases. You just can't exhale as normal. So FEV1 would decrease. In fact, it's significantly decreased. Oftentimes, the patients will have decreased forced vital capacity, FVC, because of that additional restrictive lung disease that is also present. which is often the case. But really, just think of FEV1 over FVC, and the FEV1 decreasing significantly in these patients because they can't exhale as well, and then FVC being a little bit lower. The point is that the ratio will be below 80%. So let's draw this out on a normal spirogram. So here's the tidal volume, then inspiratory reserve volume, come back to normal, and then expiratory reserve volume. And then beneath this line, we have residual volume. So in here, we'll just label these really quick. This is tidal volume, this is inspiratory reserve volume, and this is expiratory reserve volume. And of course, from here to here, we have inspiratory capacity, and then from here to here, we have functional residual capacity, and from here to here, we have forced vital capacity, FVC, and then total lung capacity is all the volumes together. In patients with obstructive lung disease, they cannot fully exhale, so residual volume goes way up. If you can remember this about obstructive lung diseases, then everything else becomes much simpler. So if residual volume goes up, then functional residual capacity will go up, and so will total lung capacity. It's important to recognize that although residual volume and consequently functional residual capacity have increased, the ERV has actually decreased because the lungs are less able to eject the volume due to the obstructive pathology. However, the decrease in ERV is overshadowed by the huge increase in RV, so the functional residual capacity, FRC, and the total lung capacity, TLC, actually increase. Now, what happens to tidal volume? Well, tidal volume doesn't change a whole lot in obstructive lung diseases. But what happens to inspiratory reserve volume? Well, as we mentioned before, in an obstructive lung disease, it's best to assume all the functions of inspiration are fairly normal. That includes inspiratory reserve volume and inspiratory capacity, which brings me to the next point about forced vital capacity. Due to normal IRV and normal tidal volume in obstructive patients, the FVC is fairly normal. However, and this is very important, patients with obstructive lung disease often have a concomitant restrictive process taking place. Restrictive processes, which I will describe in a minute, decrease the ability to inspire. So IRV and TV, tidal volume, and therefore forced vital capacity are decreased. But that's, of course, if there is a restrictive lung disease, not an obstructive lung disease. However, it's safe to say that in obstructive patients, due to concomitant restrictive pathology, FVC can be a little low. Just don't think of FVC as being the primary problem. It can just be a little bit low. So now let's talk about the last point, FEV1. FEV1 means the forced expiratory volume in 1 second. And FEV1 is the speed of exhalation or flow rate. In obstructive patients, expiration is very hindered. So FEV1 is drastically decreased. When you see a typical spirogram in a textbook, it will not have units of time along the x-axis, because usually it's just a conceptual framework. However, if it did have time, such as seconds, you could determine the FEV1. So let's erase this spirogram and quickly draw a new one. So drawing a new spirogram with time in seconds along the bottom, or x-axis, it would look like this. So how much the patient can exhale in the first second could be measured. So we'll quickly draw normal spirogram values. So tidal volume, inspiratory reserve volume, we stop there, and then you determine how much the patient can exhale in the first second. So we'll say, starting right here, if that's time 0, this is time at 1 second, this is time at 2 seconds, this is time at 3 seconds. So then you can see this patient will exhale, and you can see how much volume the patient was able to exhale in the first second. So you'll simply take the volume here and the volume here and find the difference. And on a question stem, on step 1, you actually may only see this portion of the spirogram. So it'll look something like this. with time on the x-axis and volume on the y-axis. And then you will be expected to compare the FEV1 to a normal patient. So recall that in a normal patient, the FEV1 will be greater than that of an obstructive patient. So let's take a closer look at this on a new slide. So on the left side, we'll do a normal patient. We'll call that volume is on the y-axis, and then time is on the x-axis. So here's a normal patient. We'll just say the FEV1 is right here, and the forced vital capacity is right here. That's how much total volume the patient can exhale and get out of their body. And recall that's also vital capacity. So then you can determine the ratio, FEV1 over FVC, and for this patient we'll say it's around 70% because that's what it would be normally. So now let's have an obstructive patient on this right side. So the FEV1 right here, and FVC right here. In this patient, you can see that FEV1 has significantly decreased, and FVC has decreased just a little bit due to overlapping restrictive disease. So with an FEV1 and FVC ratio, we'll see that the FEV1 has significantly decreased, and FVC has decreased a little bit, giving us a ratio that's actually decreased to be below 70%, so below normal. It's also important to know that you can actually simply look at the decreased FEV1 to categorize the severity of an obstructive process. In other words, the FEV1 can provide very helpful information even if you don't end up finding the ratio. So now let's do a practice question. What would happen to the total lung capacity and residual volume in a patient with chronic bronchitis? So whenever you get a question like this that's asking for specific capacities or volumes, you need to draw out a spirogram. So we'll just do that really quick. So this patient has chronic bronchitis, and that is an obstructive process. In obstructive diseases, the patient is unable to exhale a normal amount of air. So there is a greater volume of air remaining in the lungs. So on the spirogram, what volume would increase? Well, we know that residual volume below this line will increase. And we know that total lung capacity, which relies on residual volume, will increase as well. As we mentioned before, the expiratory reserve volume will decrease just a little bit, but overall, the massive increase of residual volume will dominate, so total lung capacity will increase, not decrease. So now let's talk about restrictive lung diseases. Now this is a problem where the patient cannot fully inhale, and this is because the lungs don't expand very easily because they're damaged or restricted, so the patients can't get as much air inside the lungs. Another way of saying this is that the total lung capacity has decreased, and we'll discuss that more in a moment. And this could occur for many reasons and should make you think of diagnoses such as pulmonary fibrosis, sarcoidosis, or a type of pneumoconiosis. So if the patient cannot fully inhale, then they have less to exhale. So there's less air in the lungs to exhale. That means there's going to be decreased expiratory reserve volume and therefore decreased functional residual capacity, which is comprised of ERV. So to summarize, decreased IRV, tidal volume, and FRC will actually decrease total lung capacity. This is opposite to obstructive lung diseases. So looking at it a little differently, decreased inspiratory reserve volume, tidal volume, and expiratory reserve volume will actually significantly decrease FVC. Recall that in obstructive lung diseases, we just said that FVC could be a little bit low if there was an overlapping restrictive lung disease. But if we're talking directly about a restrictive lung disease, you can count on the FVC being significantly decreased. That's very important because it'll help you remember what will happen to the FEV1 to FVC ratio. So if they have mildly decreased FEV1, which just because they have a disease, there might be a little bit of overlapping obstructive lung disease, there could be decreased FEV1, but mainly think of the problem for restrictive lung disease as being significantly decreased FVC. So when you look at the ratio of FEV1 being mildly decreased, but FVC being extremely decreased, then the ratio will actually go up and be above 80%. So let's draw this out. So here's a normal spirogram, and we'll draw the lines to make it simple. In patients with restrictive lung disease, they cannot fully inhale, so IRV decreases. And inspiration is limited, so their tidal volume will actually decrease as well. Now what happens to expiratory reserve volume, ERV? Well, with a restrictive lung disease, the patient was able to inhale less air, and you can't exhale what you didn't inhale. So if IRV decreased, then you have to assume that ERV has decreased as well. And for the same reason, residual volume will actually decrease too. So with decreased ERV and decreased residual volume, the functional residual capacity from here to here will actually decrease. Now what happens to vital capacity? So we'll quickly draw that. Vital capacity. Well, if IRV, TV, and ERV, which all comprise vital capacity, if they're all decreased, then vital capacity will decrease. Not only will it decrease, but it will significantly decrease. The decrease is significant because every single component that comprises vital capacity, or forced vital capacity, has decreased. Remember, IRV, TV, and ERV, they've all decreased. So you're going to have significantly decreased forced vital capacity. So now let's just zoom in for a moment and look at FEV1 to FVC ratio, so we can compare that to a normal patient. So again, on the left-hand side, we'll just draw a normal patient. So we'll draw FEV1 right here. And of course, FVC, which is forced vital capacity. So their FEV1 to FVC ratio is going to be about 70%. So now we'll draw a patient with restrictive lung disease. In reality, the highest peak on this restrictive spirogram would be lower due to the decreased IRV, but for simplicity, I'm going to depict both graphs similarly. So FEV1, how much they exhale in the first second, has decreased, as you can see. And then FVC has decreased as well. So you can see that and compare it to that FVC. So FEV1 and FVC have both decreased in patients with restrictive lung disease. However, if you look at the actual ratio, you can see that the FVC has decreased quite a bit more than the FEV1. So we'll write significantly decreased FVC and just mildly decreased FEV1. And this creates a ratio above 80%. So in summary, think of restrictive lung diseases as primarily decreasing FVC. If you decrease the denominator, the ratio will increase to be above 70%. And for test purposes, you can think of the ratio as actually being above 80%. Conversely, in obstructive lung diseases, the FEV1 to FVC ratio changes in the opposite direction. After all, in obstructive lung diseases, just right over here, obstructive lung diseases, the FEV1 to FVC ratio, you'll see the FEV1 has significantly decreased to be below 70%. So now let's do a question. So what would happen to the vital capacity and the total lung capacity in a patient with berylliosis? Recall that berylliosis is a type of pneumoconiosis. And pneumoconiosis is a type of interstitial lung disease, which is a cause of restrictive lung disease. So in other words, we're dealing with a patient who has a restrictive lung pathology. So as with every lung volume question, we need to quickly draw out a normal spirogram. In restrictive lung diseases, remember that they have a problem with inhaling. So IRV, tidal volume, and expiratory reserve volume will all decrease. Recall, expiratory reserve volume is decreasing because you cannot exhale what you have not inhaled. So what happens to vital capacity? Well, if the three components of vital capacity are decreased, IRV, TV, and ERV, then vital capacity will decrease. And so what happens to total lung capacity? Well, we need to figure out what happens to residual volume. As mentioned before, restrictive lung diseases do not alter residual volume, which is this volume down here, although it can be decreased just a little bit. For the most part, just think of residual volume being normal. The point is that total lung capacity will be decreased due to the decrease in inspiratory reserve volume, tidal volume, and expiratory reserve volume. So in answer to our question, a patient with berylliosis will have a decreased vital capacity and a decreased total lung capacity. So now let's talk about flow volume loops. Now, flow volume loops is simply a different way to graph the information you get from spirometry, and it provides information on lung volumes as well as flow during inspiration and expiration. And you can use flow volume loops to identify different respiratory pathologies, primarily obstructive versus restrictive lung diseases. So now let's compare the flow volume loop to the spirogram, which we just discussed. So we'll keep the spirogram here on the right-hand side just as a reference. And recall that we have volume on the y-axis and time on the x-axis. Now the flow volume loop has a y-axis, but it measures flow. In other words, liters per second. And the x-axis, which is going to come out of the middle here, actually measures volume in liters. So I'll write volume, it's measured in liters along the x-axis. Be careful not to assume that the y below the intersection represents negative numbers. The numbers below the origin are positive as well. So we'll just write some units really quick just to make it perfectly clear. So we'll say this is 1 liter per second, 2 liters per second, and 3 liters per second, and we'll do the same thing to the opposite side. 1, 2, 3. So they're both positive. And on the x-axis, 0 liters of air is found on the far right over here. So as the patient inspires, on this bottom half of the graph, the volume will increase because we're moving this way. Now the y-axis here will depict how fast air is flowing into the lungs. So if the loop extends clear down here, that means the patient is inhaling very fast. Conversely, if the loop only extends down to here, then the patient is inhaling slowly compared to where they were before, down here. So we'll just complete this loop. So now let's focus on exhalation, so the top part of the graph. As the patient exhales, lung volume will decrease along the x-axis, moving closer to the right, or closer to 0. Again, airflow is measured along the y-axis. So now we're going to compare this to the spirogram. So we're going to erase this. So we know that here on the spirogram, this in here is the tidal volume. And this is the normal amount of air that is inhaled and exhaled at rest. And normally this is about 500 milliliters or half a liter. So we'll just write tidal volume equals 0.5 liters. We're going to use liters because those are the units that we're using on the flow volume loop. So on the flow volume loop, tidal volume will look something like this. Exhale, inhale, exhale, inhale. So now we're going to say that each one of these lines along the x-axis represents a whole liter. So as you can see, the lung volume is only changing by half a liter as the patient breathes in and out. It's only half a liter, which is normal tidal volume. Then on the spirogram, the patient exhales as normal and inhales as much as possible. This gives us inspiratory reserve volume. So on the flow volume loop, when the patient has exhaled as normal, they can then inhale as much as possible to reach this point on the x-axis. So this represents IRV, how much the patient can inhale. So now back to the spirogram, the patient is at this point, so over here, the patient can exhale as much as possible. So they're exhaling as much as possible. So all that's left in the patient is the residual volume. So that's on the spirogram. So on the flow volume loop, when we have the patient exhale as much as possible, they're exhaling as much as possible, and they again reach the x-axis. They fully exhaled. So all that's left is residual volume. And residual volume is from this point to this point. That's residual volume. So you can remember that residual volume is measured along the x-axis all the way from 0 to the rightmost edge of the flow volume loop. That's residual volume. Okay, now we're not done. So going back to the spirogram, the patient can then inhale as much as possible. So on the flow volume loop, the patient then inhales as much as possible. So we'll create this line. So now the inspiration part of the loop is complete. On the spirogram, this gives us vital capacity. So on the flow volume loop, this gives us vital capacity as well, or forced vital capacity. In summary, residual volume is from here to here, and then forced vital capacity is from here to here, and of course total lung capacity would be both of those added together. And tidal volume is actually rarely depicted on a flow volume loop like this, but you can imagine it being in the center here, considerably smaller than the big loop that represents FVC, TLC, and RV. But just remember that it's going to be about half a liter. Now let's relate the flow volume loop to obstructive lung disease. What happens to this loop? Well, recall that residual volume increases a lot. So this rightmost portion of the graph to 0 right here will have increased, because that's residual volume. So we're actually wanting to shift this point to the left in order to increase residual volume. So now we can see that the residual volume has actually increased dramatically. So now we will begin creating a loop for this obstructive patient. So let's say the patient is breathing at rest here, creating this loop depicting tidal volume. So the patient will inhale as much as possible, creating this portion of the loop, and the patient will then exhale as much as possible, creating that portion of the loop. And then the patient will then inhale as much as possible from that point. So now we have a complete loop. Now let's compare this obstructive loop to the normal loop. So you can see that when the patient exhales, they have a hard time doing so. So the peak flow, which was up here, they were able to exhale at a rate of 8 liters per second. Now they can only do so at a rate of about 4 liters per second. And it makes sense that an obstructive lung disease, a disease that prevents adequate exhalation, would cause this decreased flow rate during exhalation, or this change in the top half of the flow volume loop. Notice how the bottom half of the loop is a little shorter than normal, indicating decreased flow during inspiration. This is due to mild restrictive pathology that often accompanies obstructive lung diseases, which we talked about before. So now let's do the same exercise with restrictive lung diseases. So we're going to talk about a restrictive lung disease here. So I will write this at the top. And now in a restrictive lung disease, we know that residual volume has decreased a little bit. So this is 0, and this is residual volume, and it's going to decrease a little bit. So we're going to drag this rightmost portion of the graph over just a little bit. So now we can see that residual volume has decreased. So now let's draw the point at which the patient is breathing normally. So So remember, it's only going to be about half a liter. So inhale, then exhale, inhale, then exhale, and that's at normal, at rest. So then we're going to have the patient inhale as much as possible. And they have a hard time doing so. And then they're going to exhale as much as possible. And then again, from this point, we're going to instruct the patient to inhale as much as possible, thus completing the loop. So now let's look at the top. Notice that the peak flow during exhalation didn't change that much. It changed a little bit, but not a lot, because this is primarily a restrictive process, which does not change expiration significantly. However, notice that the bottom half of the loop doesn't stretch near as far down as the normal loop. So in other words, the normal patient was able to inhale at a rate of 6 liters per second. In our restricted patient, they can only do so at 2 liters per second. So this represents a restrictive process. They cannot inhale at the same rate as they could normally. So now here's a summary slide which shows the obstructive lung disease, normal, and the restrictive lung disease. And in your text, this is figure 3.4. So now we're going to talk about peak expiratory flow rate and maximum expiratory flow volume. So both of these terms, PEFR and MEFV, are two sides of the same coin, and I'll explain what I mean. When the patient exhales, the PEFR is the highest rate the flow reaches along the y-axis. So in this normal patient, it's at 8 liters per second. This is called the peak expiratory flow rate. Conversely, the maximum expiratory flow volume is the same point but on the x-axis. So we just draw a line straight down all the way to the bottom, and this is maximum expiratory flow volume. So you could get a question that asks, what disease process does a patient have if the maximum expiratory flow volume has increased and the peak expiratory flow rate has decreased? Well, if the maximum expiratory flow volume has increased, it means that it has moved left on the x-axis. And if the peak expiratory flow rate has decreased, it means that the loop has moved down on the y-axis. So what does this remind you of? You should be thinking of an obstructive lung disease. So now let's discuss the FEV1 to FVC ratio as it relates to the flow volume loop. So let's erase our previous work and recall this portion of the flow volume loop is considered forced vital capacity. How much the patient can totally bring in and out of their lungs. So FEV1 is how much the patient can exhale in 1 second. So since this is a normal patient, we can assume that the patient is able to exhale about 70% of their forced vital capacity in the first second. So we'll just say for reference that it's about right here. So we'll say this is FEV1, how much the patient can exhale in the first second. So let's look at this conceptually. If down here we have the forced vital capacity, then the FEV1, how much the patient can exhale in the first second, is simply a percentage of that. And so for a normal patient, we'll say that this is 70%. They were able to exhale 70% of it, which is why we get a ratio of around 70% in normal patients. However, if you moved this FEV1 so that it's no longer 70%, you could actually move it to the left, so it's much less, like around 50%. And if the FEV1 to FVC ratio is around 50% as depicted in this graph, what would that make you think of? It should make you think of an obstructive process. Now let's do restrictive. If FEV1 moved to the right a little bit, then you can see the ratio will be much higher. We'll actually say this is around 90% by looking at the graph. So again, this would be a restrictive process. Now don't be confused by this illustration. I have kept forced vital capacity the same in both the obstructive and restrictive patient, just so that we can carefully examine the FEV1 in both situations. Just know that FVC decreases in both obstructive and restrictive lung diseases, but there is a much more drastic decrease in FEV1 for obstructive patients, as demonstrated with the green line. So now let's do a question. So which one of these two loops has the greater FEV1? This is actually a trick question. FEV1 is actually not something you can discern just by looking at the flow volume loop. Remember, it could be here, it could be here, it could be here. In this patient, it could be here, here, or anywhere over here. Some students will look at the y-axis and see, oh, right here is 1. And they will think, okay, I think I've found FEV1 because I've looked at the y-axis and I followed the line along, and I can find a point along here and determine the volume that the patient was able to exhale. And this is totally incorrect, because recall that the y-axis is liters per second. So it's simply flow. It's not volume. So you will not be able to determine the FEV1 by simply looking at this graph. That's not how flow volume loops are very helpful. The point is that FEV1 must be given to you, or you need to have a graph that shows liters versus seconds, like this. So let's do another question. So the question asks to conceptually identify the peak expiratory flow rate and the maximum expiratory flow volume for patient A and B. The blue is patient A, and the orange is patient B. So the question is, why is maximum expiratory flow volume greater in patient B? So we can see that the peak expiratory flow rate in patient B is here. The peak expiratory flow rate in patient A is here. The maximum expiratory flow volume in patient B is here. So write MEFV, and the maximum expiratory flow volume is here in patient A. So we've conceptually identified both the peak expiratory flow rate and the maximum expiratory flow volume in both patients. So the question is, why is the maximum expiratory flow volume greater in patient B, right here? Well, by looking at this graph, we can actually see that patient B has an obstructive lung disease. In obstructive lung diseases, there's air trapping in the lungs. So the peak expiratory flow rate, when the air is moving out of the lungs fastest for the patient, there's still a lot of air trapped in the lungs. So in other words, when the patient is exhaling as fast as they possibly can, at this point right here, then there's still a lot of air trapped in the lungs, so their maximum expiratory flow volume, the volume that's left in the lungs, would be a lot higher than in the patient who does not have the same obstruction, because their MEFV is here. So let's do another question. Okay, so let's say that there are two elderly patients who are twins, and they both have severe lung disease. One has a restrictive pathology, the other has an obstructive pathology. Which one of them is more likely to blow out the candles on their birthday cake? To blow out a candle, a person needs to blow out enough air really fast. So what this question is really asking is which patient can exhale the fastest. To answer this, we need to know the FEV1. Now, one person has an obstructive lung disease and the other has a restrictive lung disease. FEV1 can be decreased in both processes, but in which disease is the FEV1 decreased the most? Well, the obstructive patient, because of the nature of the disease, has decreased exhalation. So the FEV1 should be very decreased in the obstructive patient. Therefore, the patient who is able to blow out air the fastest should be the restricted patient. So let's do another question. So let's say we have a patient who has a functional residual capacity of 4 liters, an expiratory reserve volume of 1 liter, and a vital capacity of 3.5 liters, and an inspiratory capacity of 2.5 liters. So the question is, what is the residual volume? So you are going to get many questions regarding lung volumes and capacities that will make you do some simple arithmetic. So every time you get a lung volume question like this, quickly draw a simple spirogram, like this one here. So we are given a functional residual capacity, these two volumes combined, so FRC equals 4 liters. Then we're given the expiratory reserve volume, 1 liter, and an inspiratory capacity, here to here, at 2.5 liters. And we are given the vital capacity from here to here at 3.5 liters. Okay, so now what we want to find is the residual volume from here to here. So we just look at what we have and what we need. So in order to get residual volume, we could simply add the inspiratory capacity and the functional residual capacity to get total lung capacity. So 4 plus 2.5 equals 6.5 liters, and that gives you total lung capacity. Now if we have total lung capacity, then we can simply take that, which is 6.5 liters, and subtract vital capacity to help us find residual volume. So in our new equation, we'll say 6.5 liters minus 3.5 liters equals 3 liters. And that will give us residual volume. So this pattern that I've used here is what you should use every single time you get a lung volume or capacity question. Just draw the spirogram and do simple addition and subtraction. Don't do any of this stuff in your head. It's too easy to make a mistake, and it's just so easy to quickly make a spirogram and do some quick math. So don't miss easy points. Let's do another question. If a patient exhales as normal and then inhales as much as possible, what was found? If the patient then exhales as much as possible, then what lung volume or capacity was found? So we need to walk through this using a spirogram. So the patient is at tidal volume, and then they exhale as normal, as it says, exhales as normal. And then they will inhale as much as possible, bringing us to this point. So what did they find? So essentially what it's saying is, on the spirogram, went from this point right here to this point right here. So what did they find? This is inspiratory capacity. So then the patient exhales as much as possible, all the way down here. So from that most recent exercise, what was found in the patient? Well, we recall the residual volume is down here, and if the patient was able to exhale as much as possible from the point of maximum inspiration all the way up here, then we know that what they must have found was vital capacity. So now let's do another question. Okay, so the question is, by looking at this flow volume loop below, what is the residual volume, forced vital capacity, total lung capacity, and the tidal volume? So recall that the residual volume is what the patient has left in their lungs after full expiration. So from 0 here to the rightmost point of the loop, which is where they have maximally expired. So this is residual volume. And if we count this up, they have 1, 2, 3, 4 liters in there. So we'll just write 4. So then the forced vital capacity is how much air can be brought in or out. So from this point here, inhaling all the way to the point of maximum inhalation. Or you could look at it as going from the point of maximum inspiration to the point of maximum exhalation. Either way, the forced vital capacity would be 4 in this patient. So 4 liters. Finally, total lung capacity is forced vital capacity plus the residual volume. So you're adding these both here. So the total lung capacity would equal 8 liters. So the question also asked about tidal volume. Now, this is actually not something we can determine precisely here because the tidal volume was not demonstrated on this loop. But we can assume that it is about half a liter and creates a pretty small loop like this. So we'll say from 5.5 liters, inhaling to about 6 liters, and then exhaling to about 5.5 again. So we'll say that this is the tidal volume. So we're going to assume that that tidal volume is 0.5 liters. Now I want to prepare you for the various ways you may be tested. Sometimes when you see a strange graph, it can be hard to know how to approach it. However, none of the pulmonology, physiology questions you get will be hard after finishing this section. So right here is the flow volume loop you're familiar with. On a question stem, you may be asked to focus on a single part of it, like this top half. So all you see is a graph that looks like this, with flow in liters per second on the y-axis and volume on the x-axis. And this graph may even be reversed and look like this, with volume on the x-axis and liters per second on the y-axis. And it may even show negative numbers in this case on the x-axis to represent how many liters are being removed from the lungs during expiration. Because after all, this is still the expiration part of the loop, because it's the top half. You may even get a graph that looks like this, with liters exhaled on the y-axis and seconds on the x-axis. And so you may need to be able to compare the lines and determine which line represents the greater FEV1. So if we have time in seconds on the bottom, this is the first second, you can compare these two. Which one was able to exhale the most in the first second? Well, it's clear that this top line has the greater FEV1. So they may even ask you to interpret the same graph, but with the lines moving down instead of up. So this can be liters in the lung, and then seconds on the bottom. There's 1 second, 2 seconds, 3 seconds, 4, and then 5. So if you want to determine which one has the greater FEV1, you just look at the first second for both of them, and you can determine which one was able to exhale more in the first second. You can definitely tell that this bottom one was able to exhale quite a bit more in the first second. So we'll have the greater FEV1. So let's dive into a couple more questions really quick. So the question is, which of these loops below represent a person at rest? So what we're looking at is a flow volume loop. It's only a portion of it. So don't be confused. As normal, we have liters per second on the y-axis and liters or volume on the x-axis. So this appears to be the bottom portion of the flow volume loop. So remember, the flow volume loop normally has a top portion that represents exhalation. Oh, but in this graph, we only have the bottom portion. So we're only looking at inspiration. We're trying to find which of these loops represents the person at rest. Looking at this graph, we can see that about 4 liters were inhaled right here. In this next loop, we can see they go from about 1.5 liters to about 3.5 liters, so that should be about 2 liters. And then finally, we see that this patient is only inhaling about 0.5 liter. And so if we're trying to find the person at rest, we're trying to find the tidal volume. And recall that tidal volume, unless the question states otherwise, should be about 0.5 liters, or 500 milliliters. So this innermost loop is the one that represents the patient at rest. So let's review what we learned about flow volume loops. Recall that the data for making a flow volume loop comes from spirometry. And by looking at the loop, you can determine forced vital capacity, residual volume, and total lung capacity. However, FEV1 must be given to you. You can't determine that by looking at the flow volume loop. And the flow volume loop is useful for distinguishing obstructive versus restrictive lung diseases. And by looking at the loop, you can determine the peak expiratory flow rate, which is the highest peak on the loop. And this is similar to the maximum expiratory flow volume, which is where the peak lands on the x-axis. And just remember that the tidal volume is always about 500 milliliters, or 0.5 liters, unless told otherwise. So let's do a couple quick questions. Let's say a clinic has the ability to perform only simple spirometry. What lung values will the clinicians be unable to obtain? So recall that normal spirometry cannot determine residual volume. If you can't determine residual volume, you can't determine functional residual capacity, and you cannot determine total lung capacity. So in order to obtain this volume and these two capacities, you need to either have nitrogen washout or helium dilution. So let's do another question. So let's say a patient undergoes spirometry and they have nitrogen washout. What is the total lung capacity if the functional residual capacity is 4.5 liters and the inspiratory capacity is 2 liters? So recall that when you get a lung volume or lung capacity question, you need to quickly draw out a spirogram. So we know that the functional residual capacity, so from here to here, is 4.5 liters. And the inspiratory capacity here to here is 2 liters. So now we're trying to find the total lung capacity. So the total lung capacity would be from here to here, total lung capacity. And to find that, you simply add 2 plus 4.5, which is the inspiratory capacity plus the functional residual capacity. So that will equal 6.5 liters. We were able to find the total lung capacity because this patient underwent nitrogen washout. So there's one last topic to discuss. That's radial traction and airflow. So it's really important to know that airflow tends to collapse airways. And the elastic structure of airways prevents collapse. And this is called radial traction. So while air is transferred, the radial traction prevents the airway from collapsing. Obstructive diseases have decreased radial traction, so they have a tendency to collapse more easily, while restrictive lung diseases have increased radial traction, which actually prevents collapse. So let's draw this out. So here's the alveolus right here, and then the bronchiole right here. As the patient exhales, air travels through the bronchiole like this. And this causes the airway to be pulled inward towards collapsing. However, there is radial traction, which keeps the airway open. So it would pull in the opposite direction. I'll just write radial traction. So from another perspective, a cross-sectional view, it would look like this. But the radial traction in green would actually keep the airway open as air travels through this bronchiole. So in an obstructive disease, the radial traction is diminished, so we can erase these green lines. So then what happens is when air is moving through the bronchiole, it will tend to collapse. So we'll just draw a collapsed bronchiole here, because the radial traction is diminished and the inward collapse dominates. So from another perspective, we can see that the bronchiole has collapsed because of the loss of radial traction. So this is an obstructive patient. So when the small airways collapse, airway resistance has increased, while the airflow intuitively has decreased. So in a restrictive lung disease, the radial traction increases due to pulmonary fibrosis. So we will redraw the radial traction with double arrows to indicate that it's even stronger than in a normal patient. So we'll erase this arrow to indicate that this is not referring to an obstructive patient. We're now referring to a restrictive patient. So now the airway will stay open. And it's increased just due to pulmonary fibrosis and things like that, this interstitial lung disease. And it just pulls and keeps the small airways open. So this will actually not only prevent collapse, but it will actually keep the airways wide enough so that when the patient is exhaling, the resistance is lower. So in this patient, we'll write that resistance to airflow has actually decreased. And therefore, the airflow has increased.